Hello and welcome to our very first Topic Tuesday 2022-2023. I'm very excited to be here. My partner in crime, Jocelyn Ross, is joining us, but is doing that carpool thing, so we all know and love. And so I'm going to do the introduction tonight. We're really excited today to welcome Donna Sorkin to Topic Tuesdays. She is the Executive Director of the American Cochlear Implant Alliance, which is a national organization devoted to expanding access to cochlear implantation for all who may benefit. She's had a very long career in advocacy for people with hearing loss at for-profit and nonprofit entities. She was previously the executive director of two U.S. organizations, the Hearing Loss Association of America, which was one of the very first places I went when I was a young baby mama 21 years ago. It was called Self-Help for Hard of Hearing back in that day. And I still maintain friendships from that. And also the Alexander Graham Bell Association for the Deaf and Hard of Hearing, which we do have a chapter in South Carolina, and I actually happen to be the president. And I'm very excited because these two organizations have been wonderful to me and many of the families that I've worked with. Ms. Sorkin has served for 11 years as Vice President in Consumer Affairs at Cochlear Americas, where she led public policy initiatives and other activities aimed at the broad life needs of cochlear implant users, including insurance coverage and reimbursement, habilitation for children and adults, and educational needs of children with cochlear implants. She has served on federal, corporate, and university boards, including the U.S. Access Board as a presidential appointee, and the National Institute on Deafness, the NIH Advisory Board. She previously served on the advisory board of Gallaudet University, and she holds a master's in public policy from the Kennedy School of Government, Harvard University. And we are absolutely thrilled to have her here. Ms. Sorkin, welcome, and take it over. It's your baby now. Thank you so much.
Thank you so much for having me. It's really my pleasure to be with you. My favorite thing in all the world is to share information with people who need it, and parents are at the top of the list. So what we're going to talk about today is just a tiny bit about the ACI Alliance and cochlear implant basics, how they differ from hearing aids, how to start the process if you're doing that, a bit on health insurance, because there are a lot of misconceptions about health insurance and CI. People sometimes ask how often they fail, so I'll just very quickly cover that. Who's a candidate? Where can a child receive a cochlear implant in South Carolina? And I thought I'd share just a little bit from my own perspective as a cochlear implant user, what it sounds like, because that's a very common question that people ask me. And I have had a cochlear implant for nearly 30 years. So I'm going to just tell you a bit about that. So we are an organization. It is a nonprofit, and we have three main goals. We encourage and support research on candidacy and impacts. We try to advance awareness on best practices, just as we're doing tonight with all of you that are here. And we undertake advocacy to educate and encourage policymakers and payers and others to improve access. And we are unique as an organization, as a national organization that focuses on cochlear implants across the care continuum, because we have such a diverse membership. And right now we have about 2,200 members that are cochlear implant clinicians, educators, students, adult consumers, parents, military members, and veterans. And we do that by serving them and by undertaking advocacy and research. So let's start out with what a cochlear implant is. And I've just given you a little picture there, and it's a small electronic device that provides auditory information to adults and children with varying degrees of hearing loss. And it was first approved by the FDA many years ago, 1985, and then was approved for children in 1990. So we've been providing these to children for over 30 years. They're not experimental. And the parts are this external part that sits over the ear, and then this part which transmits the signal to the internally implanted device, which is right here. And that then travels along the electrode array here that was inserted during this surgery, and then stimulates the inner ear to deliver sound. So that's how it works basically. And you can see another pictorial. So the sound is picked up here by a microphone, and then this processor, which is just a small computer, takes that sound that you hear if you have typical hearing, and filters it and codes that signal and sends it to the coil here. And then that signal is sent across the skin via radio frequencies to the internal device, which is in here. And then that is sent to the brain for interpretation. Sometimes you might hear people say, we hear with our brain, the ears are just the way in. And that really is true for you with typical hearing. And for those of us that have hearing loss, the brain is really the intellect center for this. And that's why it takes some time to learn to interpret that signal as sound. And it doesn't happen instantaneously. It takes some time for adults and children alike. And in contrast, what the way a hearing aid works, the sound is picked up by a microphone that's part of the hearing aid device here. It's amplified, and then there's a program that the audiologist has set inside of that device to have certain sounds amplified in a certain way. And then that signal, that sound, is sent via the ear mold to the ear. So it's a very different process than what we see for a cochlear implant. It's really just amplifying that sound that comes in. And so if somebody doesn't get any sound at very high frequencies, which is often the case for those of us that have a profound hearing loss, that means there's no way for that hearing aid to amplify that high frequency sound. And that means somebody will miss those sounds like a T sound or an S sound, and it makes it very hard to follow a conversation. So let's talk about candidacy criteria for children. And I'm not going to go through what the FDA candidacy criteria are, because honestly, there's so much confusion about the FDA criteria. They vary across cochlear implant centers, the way we use the candidacies. The FDA indications actually vary across devices, and many of them are out of date. And honestly, increasingly, insurance companies rely upon research evidence and not the FDA guidelines. And we're actually in the process of talking to a large insurer about SSD coverage for children, and we're essentially giving them evidence, research evidence, that's going to hopefully cause them to change their policies related to SSD. And so more important are current clinical guidelines and protocols, the individualized patient decisions and what's needed according to the cochlear implant team, and to provide support for insurance. And for what is sometimes happens with insurance, when you're first turned down, you then have something called a peer-to-peer review. And so we're wanting to help with that as well. So when should you refer a child for a CI evaluation? Important to know that clinicians can go beyond the FDA approved criteria to support what we call non-traditional CI candidacy. And honestly, that's what most of us are using today, based on medical appropriateness and as evidenced by systematic research and clinical experience. And we have just completed in 2022, just a few months ago, what we consider to be guiding candidacy referrals. And we're recommending a 50/70 guideline for bilateral deafness in children. And basically what that means is unaided thresholds of 70 decibels. So a child, for example, might have uh, 90 decibels at the highest frequencies, and then further down 70 or 60, but that unaided average of equal to or greater than 70 would mean it's appropriate to refer. Word recognition scores for an older child, obviously, in aided condition of less than 50%. If that child's only able to understand less than 50%, they would be considered a candidate. And limited progress, poor functional outcomes. And keep in mind, for parents or for professionals that are listening to this, there's no such thing as a bad referral. Parents always appreciate going in and getting information, and it may be that their child, if they're not a candidate now, will be in a position later. This is the summary of those candidacy guidelines that I was just talking about. And a child not making progress in speech and language is a candidate for referral. We know that an earlier cochlear implant leads to better outcomes. Having some residual hearing, which is increasingly the case, should not be a deterrent. Our cochlear implant internal devices and surgery techniques have changed. And in most instances, if someone has residual hearing, we are able to maintain it. And even if we don't, even if they lose some, you will always gain more than you lose. I mentioned before the referrals. We want to see family commitment to appropriate therapy, and keeping in mind that what we're trying to do always is to guide clinical decision making. That's best practice, not payer policies, not FDA, not Medicaid guidelines, but what is best practice. And now we're seeing increasingly that children with single-sided deafness are receiving cochlear implants, and they have different needs than the typical recipient with bilateral deafness, and they do require special consideration and care. And the reason we're seeing more cochlear implants for SSD is that we recognize that single-sided deafness does impact on speech and learning. And the goal of a cochlear implant in these children is to provide bilateral input to encourage the development of binaural hearing. So an important change, probably in the past 4 years or so, is to really take into consideration that these children need to hear bilaterally, and they can really benefit from a cochlear implant in their deaf side. And again, a summary of those clinical guidelines for SSD that we published recently. For a child with SSD, they are at risk for progression, sometimes in their better ear. For instance, if a child was exposed to CMV while the mother was pregnant, they're often born with hearing loss. It may start on one side and move to the other side. A diagnosis of bacterial meningitis is definitely a reason to move forward quickly, because if we wait too long, we do find calcification in the ear, and it makes it difficult to get a really good insertion in the child. If the child has hearing only on one side, they do have difficulty with localization, much more difficulty hearing in noise, and they get tired during listening in school and in other places. So again, auditory therapy is strongly recommended for these children as well. And I've given you the website to go and see this. It's free to access these papers. They were published in Ear and Hearing in the spring of 2022. So they've been reviewed in a very rigorous process. So when to review for SSD, unilateral, one-sided, moderate to profound sensory neural hearing loss should be referred for an audiological evaluation. I talked before about the 3 frequencies with a pure tone average for bilaterals of 70. For SSD, we're recommending 60, and aided speech of less than 65% correct. So where do you get a cochlear implant in South Carolina? We're fortunate to have 3 excellent centers spread out through the state. And so these 3 are actually members of American Cochlear Implant Alliance, which means they're up to date on research and clinical practice. And you can see where to actually find the contact information for them on our website. So let's talk about some common misconceptions about candidacy, because we do hear these things quite a lot. Patients must be deaf to be considered entirely deaf. That's not true. A hearing aid trial used to be mandatory. It's not so much anymore. Cochlear implants are a last resort. You pursue those when you have, no hearing left. You're not hearing a single thing. That's actually not true. And it's better if you pursue this earlier, before you are completely deaf. That's true in adults. It's also true in children, as long as the child or the adult is a candidate. It might seem that it would be cumbersome to consult a center about going through an evaluation. It's not. They're happy to see a child early and let the family know what's in store if they're not a candidate now, what to look for as time goes on. And sometimes people think that the family will be upset if they go for a candidacy evaluation and the child is not a candidate. Families are always happy for the information. Information is power. It helps you decide when to move forward at the right time. People may think that the patient is too young, the child is too young for CI surgery, and that actually is not the case, because it sometimes takes 3 or 4 months to move a child through that evaluation process. And we are now implanting children routinely at the 7 to 9 months of age. So going early is a great idea. And sometimes people think, oh, the hearing loss is too bad, or it's not bad enough, that they're not a candidate for a cochlear implant. And that isn't true. The other misconception that I often hear is, does health insurance cover cochlear implants for children? And of course, the answer is yes. And sometimes people come to that thinking that because hearing aids are often not covered, then it's also the case for cochlear implants. But in general, cochlear implants are covered by public and private insurance. Most private insurers cover, and the full continuum of care. That means the pre-op and the evaluation, the surgery, the device itself, the audiology before and after surgery, and the therapy follow-up, which of course is just critical. South Carolina Medicaid is really superlative in terms of its coverage for both bilateral and single-sided deafness for children, not so much for adults, but for children. TRICARE covers, and we do see sometimes challenges for single-sided deafness from private insurance, not so much for bilaterals, but for private. And organizationally, we are working to eliminate those, and it really is getting better. So you want to go for it even if you have private and you think it might not pay for SSD. Very often the clinic can help you move through that. So sometimes we've heard discussion about a high failure rate of cochlear implants in children, and that is not true. A number of broad studies have shown a pediatric failure rate that's of the internal device of about 5%. And sometimes those questions are driven by the fact that earlier cochlear implants had ceramic, some of them had ceramic internal devices, and kids bounce around, let's face it. And so some of those had higher failure rates than the current cochlear implants that we're using, all of which have a much sturdier internal device. So again, that 5% is about where we are based on a number of studies that have been done, and keeping in mind that other common surgeries actually have higher failure rates. Dental implants, which you may have heard of, have failure rates in the 5 to 10% range. And knee and hip replacement, very common. Implant are typically 5 to 10% at 10 years and 15 to 20% at 20 years. So we actually have a very favorable outcome with these in terms of their longevity. I will share that I received my cochlear implant in 1992, and I have had 7 upgrades of the external sound processor. As the devices have improved, they have been incorporated in that external device. The replacement is covered by my health insurance plan. And so over time, I've enjoyed improved hearing. Of course, I now have the ability to use the phone with Bluetooth. I use the phone with a telecoil. As time has gone by, my ability to pick up sounds at distance has improved. So many improvements over time. And I still have that same internal device, which I expect to have for the duration of my life. And that's actually very, very typical. So this is really not an issue at all. And South Carolina Beginnings asked me to be sure and talk about what families can do to maximize outcomes. And most important thing that families can do is to maximize wear time. To have that device on their child every waking day. And one of my favorite audiologists likes to say, eyes open, ears on. And that's really what it should be for our kids, because we're really training the ears, training the brain, I should say, for what's coming in the ears. And the second really important part is to find an auditory verbal therapist, and the clinic can help with that, that your family is comfortable with, and to help you incorporate therapy at the earliest age. And the focus for therapy now, when I first got into this field and worked at ACI Bell, it was very different. And so a mom, it was usually the mom, would take their child to see a speech language pathologist, and the child would go into the room with the speech path, and the mom would stay outside. And then when the therapy was over, the therapist would bring the child out, and the mom would say, "How did she do?" And that's not how we do it now at all. The mom or dad or grandma, whoever it is in the room with the child. And the role of that therapist really is to mentor the family on how to maximize listening in every aspect of the child's day. And we're teaching parents and other family members that they are a deaf child's first teacher, just as a parent is a child's first teacher if they have typical hearing. So really important change that has really helped us advance how our kids do, whether it's with hearing aids or cochlear implants or whatever device a child's using. We want to make sure that the family is fully involved in that process. Reading is really, really, really important. It's important for any child. I have a new grandbaby that's about a year old, and my son and his wife know that I want to see them reading to that child every single day. And of course, that's doubly important, actually 10 times as important for a child with a cochlear implant. It's not magic. I like to say it's just good parenting times 10. So you do what you would do as a good parent, but you do have to do it more for a child with a cochlear implant to help them really learn to access that sound and use it maximally. So some things that parents often ask me as an adult recipient who did have nearly normal hearing for the first 30 years or so of my life, they ask, is it true that voices through a cochlear implant sound mechanical? It's not true. During the first months of when I was activated, the sound was a little bit mechanical. There were some things about it that were hard for me to get used to, but it all smooths out. And then over time, it sounds very natural. And some people say, I've heard that everything sounds like a Mickey Mouse voice. Is that true? For some people, it is true at the beginning. But again, as you learn to process that sound and your brain learns to interpret that signal, it becomes a natural sound, a natural voice to you. And parents often want to know if their child will be able to distinguish their voice from that of another adult, and will she recognize my voice and that of her siblings? And the answer is yes. And I'm going to tell you a little bit more about that, but that's definitely the case. Will he enjoy music? Will she want to dance? Do children with cochlear implants play musical instruments? The answer is yes, yes, and yes. And that really has changed. When I got my cochlear implant 30 years ago, I was told that I would not enjoy music, that this was, at that time, we used to say it's a speech processor. And that's what it's designed to do, to interpret speech. And then we realized, and very often it was children that taught us this, that actually we enjoy music, and we don't call it a speech processor anymore. We call it a sound processor. And kids typically love music. Adults, it's more variable. It does not sound like music that I heard before, and I did play classical guitar until I was about 16 years old. So it's not like that. I do enjoy music. I do go to concerts. I go to musicals, and I hear music so much better than I did before I got my cochlear implant. And how about using the telephone? The telephone for me is great. It was the thing that my mother most wanted me to get out of this so she could talk to me on the phone. And so most of our children and adults do get use of the telephone to varying degrees. But we typically do get the phone. So that's a picture of me many years ago when I first got my cochlear implant. And if you look on my waist there, you can see what used to be a sound processor, or a speech processor, as we used to call it. It was a little box, and there was a wire that went through my shirt and then connected up to my ear. And then there was a wire that went from my sound processor to the phone. But you know what? I didn't care because I could use the phone. So that was really great. And it is true that early outcomes were more variable than they are today. I was fortunate that I moved forward quite quickly when I first became deaf. And then when I had got mine, which was in 1992, adults typically had long periods of deafness and a lot less residual hearing. And over time, what's happened is we tend to implant adults and children faster, and we have individuals with more residual hearing. And children at that time, wow, an early CI used to be 2 years of age. And now, of course, many children are being implanted between 7 and 9 months of age. And so they're doing much, much better than the early CIs did for children. For me personally, some of the important impacts, both then and now, were my ability to work. And that's going to be a big one for children as they grow up and move into the workplace, social and family interactions. My general health improved. My primary care doctor noticed that I had fewer upper respiratory infections in the winter. That might have been a coincidence, or it might have been I had so much less stress on me in terms of trying to hear and understand people. And we've been able to document for both children and adults, and certainly this was the case for me, much greater quality of life. So those are important outcomes to think about as well. And I mentioned before that I continued to benefit from technology improvements, and that I'm now using my 7th sound processor. Wow, isn't that amazing? No more boxes, and some people are using sound processors that are a little button that's on their head. I personally prefer the ear level device, but people have that choice and they can do what they want. And it has provided me really with unlimited opportunity to contribute to the work that I do with improving access to cochlear implants for children and adults. And I feel like I never would have had that opportunity had I not received a cochlear implant. Voices do belong to specific people. I can distinguish speakers around a table, and family members and others who I had known from before I lost my hearing actually sounded the way I remembered them, except for my son, who was 7 at the time I received a cochlear implant. And he definitely sounded different because he had just been a little boy when I lost my hearing. And that's what I remembered about him. I can identify a phone caller by their voice. And the outcomes that I'm sharing with you here are typical of what others say, children and adults. So I think it's really important to know what those outcomes look like. So I'm also going to leave you with some really great resources that we have on our website, and everything is free on the ACI Alliance website. We have a number of stories by parents of children of all ages, and they're really, some of them are just really, really beautiful. So I hope you'll go on and read those. We have a lot of information about insurance and what to do when you have some challenges with your insurer. We have a free webinar series. Ours is called Tuesday Talks. And it's so fun that South Carolina Beginnings is Tuesday Topics. So we align beautifully on that. And we have different Tuesdays where we have ours. So you can come on and see what those are. We have them on all kinds of topics. The first one that we had this year was called the ABCs of IEPs. So we were providing information on what to do about getting what your child needs at school, and a whole range of really great topics. So you're welcome to come on those. And we have a lot of information on what is the cochlear implant. I didn't have time to do but a very brief overview today, but we have a lot of information, a lot of Q&As, including steps to a cochlear implant. So you can go on and see in detail what that looks like, and what your child will be doing as you move through that process. And we also have some great videos on the surgery, on parent-centered therapy. We talked a little bit about that today, so you can listen to an ABT talk about that. And on insurance, we have a lot of information on insurance. So let's see, that's all I have in the way of prepared remarks, but I'm really happy to hear from you and try to answer any questions that you might have.
Hi, this is Jennifer with Beginning speaking. I'm going to take a moment and turn our attendees into panelists. That way, if you would like to turn on your video to ask a question, you may do so. Otherwise, please put them in the chat or the Q&A box.
Don't be shy.
Hello. So Donna, it really struck me when you said that it's good parenting times 10. One of the things I used to actually write like a little blog for a special needs thing a long time ago. And my husband used to laugh at me because I would talk about, well, this is just good parenting. It's just good parenting. And finally he said, well, it might be good parenting, but I feel like it's good parenting cubed. I was like, well, maybe. But it is a little bit more than, what our friends with, children who have typical hearing. But it is good parenting. It's putting your phone down and talking with your child and interacting. It's really having real reciprocal conversations with your kid, and during the dinner hour, it's being mindful of the listening environment. It's so many things, and I really appreciate all that you shared. And I see that we have something in chat.
Yeah, that's really true. And of course, it's really important to turn the TV off, so there isn't that noise in the atmosphere. Make sure that when you're trying to interact with your child or their siblings are interacting with them, that they are being respectful of the need for a quiet environment. So that's a little different than just the normal household where we often have a lot of noise going on. And I really appreciate that myself as a deaf adult. I love music, but if I'm having guests over, I don't really want any music in the atmosphere. I turn that off. But it's not magic. It's not, I don't think, it's anything really, really special. It's just really doing things that continually expose your child to language learning.
Donna,
Yeah.
this is Mary with Beginnings. First, thank you so much for sharing what does it sound like? Because I have certainly been misinformed, and I think, continuously seeking newer, better information to make sure that we're sharing things with our families. And I think the distinction that you made, that you can recognize voices, and even on the telephone, is just stunning to me. I think that that's amazing. But I'm curious, what was that learning process like for you? I've listened a little bit. I actually was listening to a YouTube video today about neuroplasticity, and there's a device that goes on the wrist that some neuroscientist has done, and your brain can interpret the sounds from the wrist. And so then I've been thinking so much about how that works. Can you talk just a little bit about what that process was like?
Sure,
learning those voices?
Yeah, and also recognize that not everybody's the same, and there are variations along that continuum in terms of how people do. I'm not unusual. I mean, I think there are plenty of us that do really well in terms of interpreting that sound. I think I'm thinking back to when I learned to use the phone, and recalling that I had, compared to what we have today, a fairly primitive sound processor, and the processor that I had initially which I received in December of 1992, was upgraded 9 months later. And that second processor for me made a huge difference in terms of my ability to understand speech on the phone and in general listening situations. I did practice a lot. My mother was my the person that worked with me the most, because she really wanted me to get this, and she was very patient. And so we set aside time every night that when I was home and she could do it, and we would practice on the phone. And typically in the beginning, until you're learning to deal with that sound, we would have kind of close that. So we would say, okay, what we're going to talk about today is, what I bought at the supermarket, so I would have some sense of where the conversation was going. And so we practiced that way in a close set manner for a while. And she was very encouraging. She would say, oh, you did so much better today than you did last week. You got most of what I said, or you got half of what I said, so it can be frustrating because you're trying to do something that's fairly hard, and it does take practice. It does take training your brain to interpret what you're hearing. So I did it that way initially, honestly, with that first sound processor. That was when I was at what was then called Self-Help for Hard of Hearing People. And I used to take calls on the phone, and a staff person would be sitting with me in the same room. And we had two phones. So I would have a phone and a staff person would have a phone. And if I missed something that the caller was saying, she would repeat it. And so we went through that for a while I was learning to deal with it. And the biggest change was when I got an upgraded sound processor. I went within the space of probably 2 weeks to getting really sweaty on the phone, am I going to be able to do this? To being able to have a normal conversation. And I remember the first time I did that, I was talking to a hearing scientist, actually someone from South Carolina. It was Judy Dubno at a Medical University of South Carolina. And I was talking to her about a research symposium that she was helping us organize for Self-Help for Hard of Hearing People then. And I didn't tell her I had a cochlear implant. And I got through that whole conversation with her. And then I told her at the end, and she said, oh my gosh, I had no idea. What I'm saying is it took time. That was probably 10 months post activation with a new processor. And am I always perfect on the phone? No, I'm not always perfect on the phone. If somebody has a thick accent, that's going to be harder for me. If someone talks very fast, or if there's not a perfect phone connection, I will have more difficulty. So I do not have normal hearing, and I know that, but I have strategies that I use to help me get through those conversations that are more difficult. And of course now everybody uses Zoom anyway. Who has a normal phone call anymore? we see the speaker, and we have captioning just as we do here for this this event, but honestly, I'm not looking at it necessarily when you all talk to me, because you all have such clear speech. But I guess what I'm trying to say is it does take time and it takes practice. And there are tools that people use, and I have a whole array of them that I recommend to people that they practice with. And the biggest thing is getting comfortable with it, recognizing that you can improve and you can do it. And it was an important outcome for me. So it was something I did work on. That's a long answer to your question.
So we have from Teague a message in chat, and she says, thank you. I didn't realize the failure rate of the device was only 5%. Out of curiosity, do you know the rates for children who do not receive optimized outcomes, either due to wear time or by the child not receiving follow-up therapy services?
I can't distinguish between children who don't have therapy and children who do. I can't imagine a child not receiving therapy services. And we actually have a position paper on this that's on the website if you ever need it to be able to make a case to insurance. A child should have at least a year of post-surgical therapy with someone who is trained to work with a family of a child who has a cochlear implant. I think likely most of the time when we see children who don't develop listening and spoken language, it's because they haven't had that therapy follow-up. This is the same as a knee replacement or a hip replacement or any kind of intervention in which we provide aftercare along with this surgical intervention. And we should always be ensuring that families are committed to that intervention. I have seen some clinics that require the families to sign a contract with the clinic that they're going to follow up on the therapy. And if they aren't committed to that therapy process, they shouldn't be getting a cochlear implant for the child. So I don't know what the answer to your question is. I can say that I would not expect a child who doesn't have appropriate therapy follow-up to not do as well.
Thank you. That's an excellent answer, because a lot of times I think too, Donna, that we don't really know what happened when, if they weren't being followed by a listening and spoken language therapist, or if they weren't wearing the device, that wear time is really impactful, because it is about the brain getting used to and learning to understand the sound that's coming to them. So yeah, so we really would encourage our families to, request the listening and spoken language therapy for all their, I do for all my kids that have hearing loss, whether they're using hearing aids or cochlear implants, because it's just really important to learn to listen so that your brain can learn how to take it all in and work with it.
The other factor is the age of the child when they received the cochlear implant, because we do know that children who are implanted earlier do better, because they're starting that process earlier, and we often talk about one's hearing age, and the child's hearing age regardless of their chronological age, begins on that day that they're activated with the cochlear implant. So if they aren't receiving a cochlear implant until they're 2 years old, that means they're 2 years behind when they start. But if we can get them with the implant when they're 7 or 8 months of age, then that means that's how far behind they are at that point. And what a therapist will help the family to do is develop more language than you would expect in a 1 year period. So you're trying to make up for what the child didn't have during that period, so that by the time they're 5 or 6 years old, they're at grade level with their typical hearing peers. And that's that whole thinking about it's good parenting times 10, because you're making up what the child didn't receive in those months when they didn't have sound.
Right. Yes. Yeah, you're exactly right. And we are making up for that time. And, and that is intentional, because we're, using the tips and the strategies and the techniques through those the habilitative therapy that we're receiving in order to do that in our home, because our therapist is not going to teach our child how to talk. Right.
And you have excellent cochlear implant centers in South Carolina, and I'm certain that the team will say to a family that this therapy is part of the intervention. And you cannot do one without the other. Now, I can say that I wish adults had the same access to therapeutic follow-up that we expect of children. But we're not there yet. And adults do have the option of doing self-directed therapy. There are computer programs, et cetera, that you can use. And all of the cochlear implant companies have apps that they encourage adults to use. We actually have on our website a blog that's written by a speech language pathologist. And when she started writing it, she at first didn't want to do it because she said, but everybody should have therapy. She's Israeli, and so she's used to what they do in Israel. And I said, yeah, I know they should, but not everyone has access to it. So you have to write this for people that don't have access to therapy. So I wish we did the same thing for adults that we expect with children. And I won't go into why that is the case now, because we don't have time and that's not the focus, but it is part of the intervention for children.
We do have a couple of more things that come in through chat. So Abby, thank you so much for coming tonight. Abby Miller says, I have a 2-year-old with 2 cochlear implants. Some days she does not want to wear them. Any advice on how to get her to wear them? What are some reasons why you wouldn't feel like wearing your devices, like a headache or tired, etc.?
How old is the child?
2.
Ever heard of terrible twos?
Yes, unfortunately.
She's just exerting control. It's just like any kid exerting control over you. And she's just being difficult. That's what I think. My son didn't have a hearing loss, but he, used to do stuff with us, and it was just him exerting control. I think you have to, sit her down and explain that this just isn't acceptable. She has to wear it. There's just no getting around it. There's some really successful adults who had cochlear implants as children, and I've heard they did this. I mean, there's Rachel Chakoff, who was the the poster child one year for the annual hearing day. She wrote this article about my mother sat on me. And she didn't really sit on her, but she, she sometimes had to force Rachel to put her cochlear implants on, and she's a strong-willed person. She grew up into a strong-willed adult. So I think that's probably what's going on. I would talk to your audiologist at your clinic and ask his or her thoughts on why they're doing it. But I think it's a phase without knowing your child.
Yeah, thank you. Thank you so much, Donna. So yeah, and also Abby, hearing aid retention devices, they do come in handy with the terrible twos. And again, that was excellent advice to consult with your audiologist as well, just to make sure that the mapping is spot on. And yeah, so that's really great. And so we piggybacking on Teek's question, the failure rate for children, does that include the kiddos who don't get services, or is that a medical failure?
So when I say failure rate, I'm talking about the internal device failing. Okay, that's a mechanical failure of the internal device, the part of the cochlear implant that's placed inside of the head during surgery. So when we say a failure rate, that's what we're talking about. We're talking about the internal device failing. And so let's see, what was the question? Failure rate. You mean that's an issue where you have a surgery and you have the failed device taken out and a new internal device put in. So that's what I'm talking about when I say a failure rate. What was the question? I'm trying to distinguish between that aspect of it. Was the questioner asking about children who don't do well with the device?
Hey, Donna, this is Mary. So I think, Teague asked a question. I'm sorry, Lisa.
No, go ahead.
And it kind of got me thinking, because sometimes parents will talk to us, well, how often does it not work? And so when I hear failure rate, my assumption was that it was, medically speaking, the device, there's a problem, it's not working. And we know those cases. But then also, because unfortunately, I think just based on the sheer number of families that we serve, we have a significant number of children who've received an implant, did not get services for, a plethora of reasons, and they don't have good outcomes. And so I think just trying to kind of think of what does that look like. I know that is, those numbers are lessening, but we, still find ourselves in South Carolina facing that a lot. So I really was just kind of trying to clarify that the failure was from that medical aspect and not good outcomes.
Right. And I just can't emphasize enough that the therapy follow-up where you're mentoring the family is inseparable from the surgery. I think we should go back to the days the early centers used to make the family sign a contract. And if a family isn't going to follow through on the recommended therapy, they shouldn't do this. I am not someone that says every child should get a cochlear implant. I don't feel that way. I feel that it is a choice and an option, and families have to understand what is involved for their child to be successful with listening and spoken language. And maybe they decide that they don't care if the child gets spoken language from their implant. They're really just looking for awareness of sound. I don't know whether it's worth it for that, but there are some families that approach it in that manner. And I just keep emphasizing that the therapy is inseparable from the surgical intervention. You can't have one without the other and expect the child to follow through. The family has to have it has to do the therapy. The family has to have the appropriate follow-up. The child has to have support at school. You know, and the family has to know what they should be seeking for their child at school so that they can be successful. And some families will decide that they want to combine what the child is hearing through the cochlear implant with sign support. And if that's what the family decides they want for their child, that's a family decision. And we support whatever, as you know, we support whatever the family decides that they want to do for their child. Age that the child receives a CI is critical. You know, that's why we say earlier is better. Is it the case that child who's implanted at age 2 can't develop spoken language? No. Do we recommend waiting till age 2? No. There is a wonderful story on our website that we just published. The child is the voice of El Defo. Have you all seen that? Yeah, so the child whose voice is Cece was adopted from China when she was 2 years old. And she came to the United States with no language. She didn't have English. She didn't have Chinese. She had no sign language. She had nothing. And the family, just an incredibly focused family, went forward very quickly. They had her in the clinic 3 days after she arrived in the US. She was implanted shortly after that. And the mom and the family did everything that they could to help her develop language with her cochlear implant. And she is an extraordinarily amazing child. You know? So it isn't an absolute, but we don't recommend it. You know? And so that's, you know, and again, it comes back to what the family's interested in doing. You know, is the family going to follow through and do this in this way? And is their ultimate goal to develop spoken language?
Right. Thank you so much. We really are, we're like at 8:02 now, but I want to say thank you, Donna, because this was all just beautifully done. Your presentation was wonderful. We have a new message here. Let me check that. Oh, another thank you so much. So I appreciate everything and want you to know that, you know, Beginnings is dedicated to helping our parents understand all of their options. We also want them to know what it takes. And because whatever you choose for your child, you must do 100% with the support of the specialist and, you know, service providers who can support you in that, on that path. That is the key. So I want to say thank you so much for being here today. I can't wait to attend some Tuesday talks, and I will be sharing that. I know that I shared the first one that you guys had out with my family. So thank you for coming. And
it was my pleasure. Thank you for having me.
okay, good night.
Bye-bye.